as refined, as good a surgeon, as academic, and as good a colleague. Um, and I think he undersold you a little bit, George, because you have even exceeded that.
Thank you.
Um, uh, he's been a fantastic colleague and a great leader, and it's a pleasure to introduce you and have you speak here. Um, and we're also pleased to have Josh Rosenberg. We all know Josh as bailing us out and working with us to help with the facial reanimation and uh, the very difficult problems that sometimes arise after our skull base approaches, particularly at the brainstem and involving the facial nerve. And as you can see, his pedigree is also outstanding. Um, I used to think that a facial reanimation procedure was a little incision here and a little incision there with a little sling. Um, and then I had the opportunity to see you do one of those and realize that it is a major type of reconstruction that is done to make these patients do so well. So it's a pleasure to have you both. And with that, I'll turn it over to George to get started.
All right. Thank you, Josh. Can you share my screen, please? Again? Can you see it? Let me see where I am. Okay.
You do not see it.
All right. Let me know now.
Yep, that's good.
Okay, and you can hear me. Good morning, everybody. Thank you so much, Josh. Really, after a decade at Vanderbilt and before being at Sinai, you guys, the whole Department of Neurosurgery welcome me as one of yours and makes my job and my life easy. Plus, I did learn and continue to learn a lot from everybody there, and I'm really honored to be part of this group. So the talk, honestly, and I tried to gear that, I thought about how I'm gonna present today about the small organ of the body, the ear, and then how I'm gonna present it for the neurosurgeon. So I tried to make it a talk that just, at least the common terms would be familiar, mainly for the resident and people who are not involved in what we do as far as tumor surgery and hearing surgery. And with that, I outline it as far as like talking about the hearing loss, what's specific in the hearing loss and vestibular schwannoma, how it's unique for it, and defining what's really asymmetrical hearing loss versus single-sided deafness, and what's caused the hearing loss in vestibular schwannoma, and then talk about the management from hearing aid to cross to cochlear implant, and I will touch a bit on auditory brainstem just to be complete with the hearing rehabilitation talk for the vestibular schwannoma. So Helen Keller, she was born in 1860 in Alabama, and she was a deaf and a blind, and she was the first deaf and blind who finished her Bachelor of Arts. And then she wrote that, which was very, really deep. And she said, blindness cuts us from sayings, but deafness cuts us off from people. And then her quote is, after a lifetime in silence and darkness, that to be deaf is a great affliction than to be blind. Hearing is the soul of knowledge and information of a higher order. To be cut off from hearing is to be isolated indeed. And definitely, when you talk about people who lose their hearing, you can see how much they become emotional and that we start to quote stuff that we take it for granted, but really it's amazing as far as sense of the human being. So just to simplify the temporal bone and where the hearing is. So if you take the ear canal, as you can see here, you do have the eardrum. There's a small ossicles here, 3 ossicles. And the role of the ear, honestly, is to transmit the air sounds as air wave and have the eardrum basically vibrate those 3 ossicles. And then the vibration will create a fluid wave inside the cochlea. And after that, it creates a action potential where it stimulates the cochlear nerve through what we call the inner ear, and then you will transmit sound. And that's the typical way the normal human ear hear. So when we order the audiogram or the hearing test, this is basically what we are looking at. If you look at a schematic of the hearing test here, we test the frequency or the pitch, and we go from low frequency to a higher frequency. And 250 to 8,000, this is where most of the limit of the audiogram is, and the frequency where the human ear usually for adults is hearing. And on the y-axis is basically the loudness, or basically the volume. And if you are from minus 10 decibel, that's how we tested, to 20 decibel in all frequency, as you can see in yellow here, that's considered normal hearing. And then if you go from 20 to 40 mild, then the more you lose hearing, moderate to severe, and then more than 90 dB hearing loss, that's considered profound hearing loss. And the sign, when you see that on the audiogram, when anybody look at, the round or circle are for the right ear. So when they test each frequency with each tone and volume, you can see for each frequency, they put the circle for the right ear. And same crosses will be for the left ear. And when you look at a complete audiogram for a patient, you will look at the right ear and circle and the left ear and axis. So if somebody has a hearing loss in the right ear, for example, it's very now after you understand how the audiogram is scattered, you know that those circles for the frequency is gonna be dropping below the 20 decibel. And as far as the lower they drop, the more severe is the hearing loss. But that's not a lot about the hearing. We talk about only the tone for the hearing. Another key component for the hearing, and that comes in handy for patients with acoustic neuroma, is the understanding. What we call it word recognition score. So which means if I give you a name like hat, you can repeat it after me as hat, regardless of how high I give it to you. If you don't have a good discrimination, you're not going to be able to repeat it correctly. So the testing usually is based on 10 words that if you repeat all of them correct, you get score 100%. And if you repeat one or two or less, then you can decrease your scoring. And to be considered normal discrimination, you need to have a score in each ear over 90%. So you need a good discrimination and you need a good level of hearing or volume to be considered a normal hearing test. In order to make it more usable for anybody to look at it, the Academy in 2013 came with a classification that can divide people with hearing loss with serviceable or non-serviceable. And if you are what we call in the Academy Class A or Class B, which means you do have in the Class A 30 decibel, no more than 30 decibel hearing loss, and more than 70% understanding, you're considered Class A, or no more less than 50 decibel hearing loss and better than 50% discrimination, you're considered Class B. If you are A and B, you're considered a person that has serviceable hearing, which means if I give you a hearing aid, you're gonna benefit from it. However, if you are a person who has less than 50% discrimination or more than 50 decibel hearing loss, you're considered like a non-serviceable hearing, which means a hearing aid for you gonna create more noise and I'm gonna make you uncomfortable. It's not gonna help you hearing. So what about acoustic neuroma, since this topic is about hearing rehabilitation in vestibular schwannoma? We know for a fact that all patients with acoustic neuroma, at some point, if you see them and test them, they do have some form of hearing loss in up to 90%. And if you take the first symptom that a patient with acoustic neuroma presented for, more than 50% of them are presented for hearing loss. And that was in a large series that the Mayo published, and also in a paper that we published. It's around over 50% patient with vestibular schwannoma present with hearing loss. And the prevalence of hearing loss of the vestibular schwannoma also, with time, it will decrease, which was very interesting. We really did not know a lot about that. And that's very important when we talk to our patient, to be honest with the data. Back in 2000, I think 16 or 17, when I was back at Vanderbilt, we did look at 590 patients that we observed over the year. And we did look at pure tumor observation over time for growth and for hearing loss. And we realized that like if you wait a lot on even the tumor that you observe, and this is an average of 10 years, more than half of those patients will lose their hearing. And another study that came again from the Mayo people, and Matt Carson used to be my fellow at Vanderbilt. He published a lot on that. Also, when you look at many patients from many series, he realized also with time, over 7 years, patients with acoustic neuroma will have or will lose their hearing progressively, whether you do it from radiation or from watching or even from surgery. And depend which center, it's called differently. But it's important to tell the patient that the hearing loss is something going to happen with time in patients. And it's very important to disclose that. So what's specific about the hearing loss in the acoustic neuroma? So if you take the hearing test on the left side on your screen, you see this is a hearing loss in both ear, right and left are symmetric. And when both hearing loss on the right hand side are on the top of each other as far as curves, that's considered symmetric. We consider asymmetric hearing loss, which is what you see on the right side, in when there is difference between the hearing between one frequency at 30 decibel, or two consecutive frequency at 15 decibel, or three consecutive frequency at 10 decibel. So when there is discrepancy of that amount, that will consider asymmetric hearing loss. And that will be very specific to what we call retrocochlear pathology or single cycle deafness that you need to rule out. So anytime we have a patient, and that's a board question, that present with asymmetric hearing loss, it's extremely important to get an MRI to rule out retrocochlear pathology. The incidence of finding an acoustic vary from series to the other. Initially, we thought that it was less than 1%, and the number that is coded from series of 500 asymmetric hearing loss was like 0.5. But as we start to study more those patients, we realize that it's a little bit over 1%, and some data is suggesting that could be up to 2 to 3%. So whether 2% or 1%, if you have asymmetric hearing loss, it's important to get a MRI to rule out retrocochlear pathology. So why this is important, and this is more of for the just from 30,000 feet discussion about asymmetric hearing loss. Why is it specific and what it causes to patients with acoustic neuroma? Well, the problem with two ears and missing one is mainly what is very specific to human. So if you drop a hearing on the high frequency or unilaterally in one ear, you're going to be very challenged in restaurants and background noise. And the two ears will add more volume, what we call squelch in the audio world. And if you lose one of them or you decrease hearing in one of them, those patients will tell you when you consult with them, they're very, very unhappy in environment when there is noise, especially restaurants. I really don't want to go out. And another important factor of losing hearing on one side is knowing where the sound is coming from, or what we call sound localization. And why is that? Because for us, and this is mainly based on human and survival, for us to be able to tell where the sound is coming from the right or the left, there is two physiology or mechanism we can follow. One is the time, what we call the ITD, that the sound hit the ears. It's a 1/10 of milliseconds that if you are on the right side and the sound hit you on the right side, the right ear will get that sound split of seconds before the left ear. And that's enough time to tell the brain that the sound is coming from the right side. So if you lose that interocular time difference because you lose hearing on one side, you're gonna lose that physiologic response and you're not gonna be able to localize. And the other one is the loudness, and let's go for the high frequency. If the sound is loud on the right side more, then you can hear it a little bit louder on the right side more than the left. And then because of that, you can tell that it's coming from the right. And depending on the frequency, you will need two physiologic mechanisms to be able to tell where your hearing is coming from. So if you lose one hearing, which is specific to acoustic neuroma or something else, you can realize that sound localization might be a problem in those patients. But how we lose hearing in acoustic neuroma? Well, the obvious answer is if you get radiation, you can lose it with time. Or if you get surgery, whether you preserve the nerve or not, sometimes the hearing will drop a lot. And that depends a lot also on the size of the tumor. And also, if the tumor does grow on or observe, you can lose hearing. But what's specific about the observation for the acoustic is different way of people looking at it. One was like the tumor will be pressing on the vasculature of the hearing nerve as it grows and kind of creates some form of ischemia, and that's one theory of hearing loss. The other is the tumor will grow inside the inner ear, so it goes beyond the internal auditory canal, become intracochlear or intralabyrinthine, and that will be enough to destroy the cochlea and destroy hearing. And the third one, that or third theory, there was some protein secretion that could be neurotoxic, and that also will allow patients or get patients to lose their hearing. So different physiology for hearing loss, but the bottom line that time, even with not doing anything, can cause some hearing loss, not in all the patient, but in a good amount of patient if you wait long enough to watch the tumor. So what we will do for those tumor, and this has become very tricky because it's very important to know what's the status of the other ear and what the patients do and how it's impacting their life and what's the most difficult thing for them. And then you can be able to help them with how they want to having rehabilitation. And then also it's very important to know that is the other ear being affected or not, because that's create a little bit challenge for the audiologists in order to rehab these patients. So the earliest thing and the easiest thing to do for patients with acoustic neuroma that still have hearing is to use a hearing aid. And there is different form of hearing aid, as you can see inside the canal, behind the canal. That's a different lecture, but there's different type of them that the audiologist can go over with the patients. But the key for a patient with an acoustic neuroma to have a hearing aid on the side of the acoustic neuroma is to have hearing. And if you look at the chart, not only they need to have hearing between the mild and the moderate to severe, which is the blue here, they need to have a good understanding over 60% to benefit from the hearing aid. So these are basically small acoustic neuroma. When watching, they do have some form of hearing loss. They still hear, but not very happy with their hearing. They have good understanding score, and you can give them a hearing aid. Some of them will be happy. Some of them will tell you that, you know what, I'm fine. I don't want it. And what are the pro and cons of hearing aid for that? The pro is basically there is no risk. It really does work well on a lot of patients. And then some people feel some benefit when there is ringing in their ear when they wear it. And why is that? Because the hearing aid will allow to sound and noise to come into the ear and then distract the brain from the tinnitus. And definitely there will be improvement of the binaural benefit, which mainly if somebody's talking, you can get this addition of the second ear, what we call squelch. The problem with hearing aid, as we all do, not all insurances cover it. They can be very expensive. There's other problem with that block inside the canal, and they sometimes require replacement almost every 5 years. All right. So what other than hearing aid we can offer to the patient? Let's say the patient has hearing loss that is not aidable on that side of the acoustic, whether the tumor grow a lot and or he has complete hearing loss, or we did surgery for him or radiation and he lose hearing. In that scenario, what you can do is we can do like contralateral routing of the signal. What that means is what you see on the screen exactly. You put the hearing aid on the bad ear or the ear that does not hear, and you put another receiver on the good ear. And what it is if the sound is coming from the left side, it will be crossed to the good ear, and the patient will hear it in the right ear in that scenario. And if the patient has hearing loss also on the right ear, now that will be called bicross, because you will need another hearing aid on the good ear. So you will have a hearing aid that will pass the sound to the ear that already has a hearing aid. So both forms are to cross the signal from the acoustic neuroma ear that does not hear to the contralateral ear. And that could be done also by surgery, which is we call the BAHA, if you hear about it, or the bone implant, where you put a screw in the skull, and that screw, it's a titanium, basically screw, it osteointegrate, and then you add a hearing processor that clip to the screw, and that will do exactly the same like the previous picture, but in this scenario, you don't need a receiver on the right ear. The sound will use the skull to go through the other ear, through the bone, and then patient will hear on the contralateral ears. And these are different form of them. They can go percutaneous or they can be on a magnet, but exactly it does the same as crossing the sound to the other ear. So what are the advantages? The advantage is if mainly the head shadow effect. And mainly you hear that from spouses more than anything. If somebody has hearing loss on the right side, they're driving, that's an example, and his spouse is sitting next to her or him and said, he cannot hear me when I drive. Is there anything he can help, or I need it specifically for that? And that's a perfect example for what we call head shadow effect, which means if somebody's talking to you on the bad ear, you're not going to be able to hear it, and you're going to keep turning your head and you say, what? So if I cross the sound with a cross hearing aid, if anybody's talking on my deaf ear, I don't need to turn. The sound will cross to the other side and the patient will be happy with that. And then that's how we hear the sound. However, if somebody's talking, if there is somebody talking to you on your good ear and there is some noise coming a lot on the bad ear, sometimes also that technology will pass the noise to the good ear and patient will not be very happy. So it's not perfect, but definitely it has an advantage. So if you take the cross routing of the hearing, the pro definitely will be that it's gonna enhance speech when there is noise, and it is covered by the insurance, so patient don't have to pay for it. It's different than the hearing aid, but definitely you're not gonna have the binaural benefit because your hearing is already gone, and you cannot localize. And localization, if you don't have two hearing, it's almost impossible to do with any device. Then that will take me to the cochlear implant. And I do get a lot of consults on cochlear implant uh, for many reasons, but also some of them are for tumor. And I felt that it's good to talk about cochlear implant and how they work so we'll know which patient we can help and which patient we cannot. The cochlear implant was FDA approved in 1985, and it was FDA approved for kids in 1990. And it's the single most basically important prosthesis that's been designed for a sense since that time. We're still waiting on the eye implant, but for now, for hearing restoration, this is definitely it's something that has changed how we practice and changed the life of hundreds of thousands of patients. So the cochlear implant basically has an external receiver. I'm going to go over that. Has an internal receiver, an electrode that goes into the inner ear. So this is where the patients wear, that's called behind the ear implant. And there is a magnet attached to the internal receiver, which is that will be go on. I have a case now after this talk that I will put that for the implant under the skull. And the electrode, which is you see now, this is precurved electrode. Some of them are straight, that goes inside the cochlea. So this is from my friend Matt from the Mayo, but I'm just gonna play it to you to show you the difference between the two. This is a hearing aid animation. It will tell you how, or regular animation, how the hearing aid will work. It's just an amplifier. Sound will vibrate the tympanic membrane, as I said before. It goes through the inner ear, and it conducts the sound through the cochlear nerve to the brain. And that's how the ear works, and that's how the hearing aid works, because they are technically an amplifier. All they do is to amplify sounds to get into the ear. So that's the only thing they do. They bring more volume to the ears that need to be working. And that's an example of a patient putting it. Cochlear implants are completely different. So as you can see now, you're gonna put an internal receiver by surgery under the skull, and the implant will bypass the external ear and the middle ear. And that's the magnet that attached to the implant externally. And when you get the sound through the external receiver, the sounds go through the internal receiver electrically, not like the hearing aid where you amplify the sound non-electrically. And this is a patient wear it. And then you basically, this is an example how it's worked. You basically stimulate directly the nerve. So you bypass the external ear, you bypass the middle ear, and you stimulate. So you use the cochlea as basically a place to put the electrodes, but you are really stimulating, as you can see the sound, the cochlear nerve directly. So it goes through the electrodes, and that's the cochlea, which is basically a reservoir for or a place to put the implant, and it's gonna stimulate directly the cochlear nerve. And why this is important? This is important because in order for us to be able to put cochlear implant, you need obviously three structures. One is the cochlea. So if somebody is born without cochlea, like Michelle deformity, you cannot put an implant. Somebody has ossified cochlea, you cannot put an implant. So you need to have a cochlea, a place to house the electrode. You need to have a nerve. And why this is important in acoustic neuroma? Because if you do surgery on acoustic neuroma and the cochlear nerve is not preserved or not working well, and you put the cochlear implant, it's not going to work. So that's a cable. And definitely you're going to have a nucleus to be able to stimulate. But what changed that we start to talk about cochlear implant? What changed is we did a lot of studies before, and I've published in 2017 on single-sided deafness off-label at that time because we thought there is some benefit. What changed is in 2019 July, which is last year, the FDA did approve one brand of the implant for single-sided deafness. They found a lot of compelling data that for single-sided deafness, you can use the implant because the FDA up till that now, you only have or you be approved for an implant only if you are deaf in both ears. Otherwise, you cannot get the implant. And then a lot of studies before the FDA approval did help in that. And you see, some came from the Mayo, some came from us at that time. But the bottom line is, if you have an NF2 patient, for example, and you don't want to do any surgery, you're watching a tumor, but their tumor or their hearing is decreasing, there is a possibility that you can put an implant and give the patient 10 years of hearing before the tumor just get way bigger or the hearing nerve is not working, and then you can do a cochlear implant. And that data came from Mike Link from the Mayo Group. And also we've seen that people with single-sided deafness, where they have a small tumor, vestibular schwannoma, unilateral, you implant those, also there is some benefit. Now we have to be very careful. Not every cochlear implant is indicated for those patients with acoustic neuroma, but there is some small set of patients, if you identify them with a tumor or with a small tumor that you remove and their hearing dropped and you know the cochlear nerve is normal, you can really implant those patients. And if you have the right patients, they will do well and they'll be happy with their cochlear implant. So this is the most like basically advanced indication or expanded indication that we got on the cochlear implant. However, it's extremely selective in order to have the right patient and have the patient be happy about the surgery. And I'm almost done with my talk, and I hope I covered the broad management for the acoustic neuroma. I will be missed if I don't mention the ABI. I was involved early in ABI and I stopped doing them because our result, at least I'm honest about that, were at best terrible. Not a lot of people like to say that, but at least in our group at Vanderbilt, they were not that good. And we decided that either we're not good surgeon and we don't know how to do it, or there is something else we need to understand about the ABI. However, I want to mention it because it does have a room, and I think it does have an indication, but we still need to understand more that technology. ABI stands for, there is resident from the ENT, for auditory brainstem implant. I think it's extremely important to know the anatomy, the lateral recess, the choroid plexus, and where the lower cranial nerve is. Because when you place those implants and you do it with the retrosec approach, you need to have basically monitor the vagus nerve, because it's very important when you activate them on the first time, you be in a set that the patient might stop breathing because stimulus can go to the lower cranial nerve. So you need to have in a setting where you are in an area where you can basically activate them. And if you need to resuscitate the patient, you can do them at least on the first time. And it's very important. I'm talking to a group who knows that anatomy more than anybody else, to know what's are the really landmark to place an auditory brainstem implant. Basically, it's very important to know where your lower cranial nerve are. The choroid plexus sometimes can block or be at the lateral part of the foramen of Luschka, and your flocculus can be a landmark. And the ABI is placed on the dorsal cochlear nerve nucleus and on the ventral. There is two type of them. Only one of them was approved FDA in the United States, and that it's off the market now. And the middle one, which is it's a little bit wider, it's not yet FDA approved because we don't have a lot of patients, and people are not going a lot for the ABI to do more or trial of it to get the middle approved. And the landmark are lower cranial nerve, of course, the 7 and 8. Choroidal plexus can be, again, blocking the lateral recess where foramen Luschka is, and definitely the flocculus, which sometimes can be very large. Uh, I think it's indicated and FDA approved for the NF2 patient, and these patients really don't do that well. That's why we did cochlear implant on NF2 patients, as I mentioned before, and that was an expanded indication because you're using the whole cochlear nerve and the nucleus of the cochlear nerve. In the ABI model, you just put this electrodes on the nucleus. And those patients are, at best, they are reporting sound awareness, and they're not really very well satisfied with that. There is different type of implant. There is the P stands for percutaneous, nobody use that. And the midbrain implant or AMI or auditory midbrain implant, there have been published 5 or 10 cases, and Leonard, who's a friend of mine in Germany, have those cases. And himself, he say, I just did it to see if I can do it, but I'm not sure this is a right direction for the hearing. And with that, I really want to say thank you to all of you for your time. I hope I was able to gather some broad picture about the hearing after an acoustic neuroma, and I'm here to take any question. Thank you.
That is absolutely great. George, can you unshare your screen, please? There's so many things that you covered that I think are relevant and very, very, very clear. I'd like to ask Cal to comment in a moment, and Peter or Sadi, if you have any questions on the any comments on the ABI and kids. But I have a basic question for you. If you had unilateral hearing loss, profound or complete, how would you deal with it, and what would you recommend that we tell our patients? Because oftentimes we discuss it beforehand, and we say, you know, most people do just fine. They can live a fairly normal life without it, but there are options like the Baha implant and so on. So we don't really direct them other than to refer them. But if it were you, or if you want to give us advice, what would you recommend? You have to unmute, please.
Can you hear me?
Yes, we hear you.
Okay, that's a great question, Josh. I think it depends on the patients. It's very important to know if somebody's been with hearing loss for over 10 years, those patients don't do well with anything. They adapt to their life. And I had a failure on a patient on an implant who was over 10 years in my series at that time, and they don't do well. Patients who's been suffering from hearing loss recently, we say 1, 2, 3 years, there is two group of patients. And it's very important what they want. Some patients, they just want, if somebody, as I said before, talking to them on that side, they don't need to keep asking what, and turning their head. And those are easy to help because a hearing aid or a Baha for this do magic, and it's on their, depending on expectations, they're very happy. Some patients, the tinnitus is driving them crazy, absolutely crazy. And those patients, if you, the cochlear implants do magic for them, if the tinnitus is the primary problem for them, and then we can gear them toward that. But all the patients need to get an evaluation for single-sided deafness, where they will sit in a booth for 2 hours to see whether a hearing aid or an implant simulation or a BAHA is the right choice for them. And then after that, we will pick on what their expectations are. If you want a localized sound, let's say you're a policeman or firefighter, and that's very important for you, the only device that could be a possibility is the implant, but they need to wear that. Uh, they need to wear that a lot. Actually, I had a patient of mine made a YouTube. He's a musician. I implanted him for his tinnitus. He made a YouTube a song. Like, I'm all over in 2016, all over YouTube. I said, great, this is the doctor who made me deaf and put a cochlear implant for me. So he's very happy. So it depends what's their expectation, but we know there is a broad range of what we can offer. Depends what they want, and that what they want. For me, for example, I probably will be with a hearing aid or BAHA if the tinnitus is not bothering me, but I will be open to cochlear implant if this is, I cannot sleep for my ringing. Absolutely. So.
I will point out or just mention from my own experience that about 4 years ago, during some international travel, I came down with a virus that made me, over a period of 2 hours, completely deaf in one ear. I saw Eric Smuha, and he injected my ear with steroids. Um, didn't work. I went on to a big international trip, and for about 6 months, I had no hearing at all in my right ear. I did adapt, but I found it quite disabling. And Eric told me not likely that anything would come back. It came back,
That's great.
and not completely. Still worse on the right. The difference has been really interesting and significant.
Right.
So I don't underestimate it.
No, absolutely. You know, one of the neurosurgeons that I work with, I'm not going to mention him, has sudden hearing loss and never recover. And it was very hard in the surgery because everybody talked to him on that ear to be able to listen. So he ended up wearing a cross, but he does not wear it outside the OR because he hated it. But everybody was telling him, hey, listen, talking to him, and he could not tell what's going on. So we forced him to get a cross in a way. But the minute the surgery is over, he take it out and then throw it. It is disabling for sure.
Dr. Post, you're the one here with by far the most experience in this area. Can we get some thoughts from you on it? Let's see. It looks like you're muted.
Okay, now can you hear me?
Yes.
Okay. So this talk was terrific. Historically, it's interesting. You know, when I first started as a resident and young attending, having the patient survive acoustic surgery was important. Then we went to focusing really entirely on the facial nerve, and keeping the facial nerve functioning as much as possible. And then we started to deal with hearing, trying to save hearing. And in Lenny Malice's 600 cases, he was concerned about facial nerve and survival, not hearing at all. My 550 or 575 cases, the last, 10 years, we were focused on saving hearing because the facial results were so good. But we never totally considered the after effects of hearing, whether lost by the tumor itself or lost by surgery. And this just stresses the importance of the team approach. We've always felt the team approach was key, not just for drilling the canal, but for animating hearing afterwards. And I have a couple of friends who have cochlear implants in now, and it is amazing how functional they are. So all of these devices and thinking about it is, I think, crucial in the current day treatment of retrocochlear disease, particularly acoustic neuromas. The cross hearing aids have been around for a long time, and initially patients didn't like them because of the echo effect that they had. But I think with the current techniques and better instrumentation, it's all terrific. But again, it just stresses that you can't deal with this disease without having a sophisticated team like this. And I thought this presentation was just perfect.
Yeah, me too. Raj, you have
Yes. So I have a question for George. First of all, fantastic talk, George. What's the durability of the cochlear implant? Because I know its use has been increased, and I would imagine you're putting it into such a small anatomic space. Can you get fibrosis? Do you have to revise them? How do you monitor them? Or do you have like things like osteoneogenesis? Are there other things that complicate this?
All right, thank you. So the cochlear implant is designed for lifetime, but we know that is not the case. There is 6% take back on the implant. The majority of them are due to, believe it or not, skin issues because of the magnet that is creating some ulcer on the skin and then can cause infection. And as the implant now become 3 Tesla compatible, we're dealing with other issues now. Because they have to make a new magnet that is compatible, so it's weaker. So we would know what's kind of the problem. The heart failure of the technology is extremely rare. It's less than 1%. But mainly 6%, it's a take back. The fibrosis, it does not matter in the cochlea because the electricity really is going through the cochlear nerve. Trauma, they're very resilient. I mean, I have another talk on that on trauma. I mean, professional people can wear the implant and still do sport. But overall, 6%, I don't think it's going to go below that. Not only related to implant, related to also site of surgery and skin infection.
Sadi, do you have any comments on your own experiences or ABI or NF2?
I wanted to talk about ABI. Can you hear me okay?
Yeah, we hear you.
ABI, you know, George teased me with a potential case one time and it went away, sadly. So I'm sorry to hear that, but I do think that it's the ideal implant for a young person and that we have a chance to make a difference. George, what do you think the failure really is? What's the technical failure in this case? Is it placement or is it the electronics?
I think it's both. In your case, Sadi is different. These are patients that they will do well. We're talking here about just let's discuss it. The ABI that Sadi is talking about is patients, kids who have no cochlear nerve, but they have a normal anatomy in the brain. So there is no scarring, there is no tumor. It's different than NF2. Our experience with the NF2 patients, these are patients has a lot of other slew of problem and the scarring, and sometimes the ABI is not put well, or there is not perfect ventral cochlear nucleus because of many other issues. The kids is different. They have a perfect anatomy. There's not many of them with absence nerve that you see. There's 5 cases, I think, initially was presented or done in the US, and then they did another 5 in Los Angeles. The data on that, because I know both of the PI on this is okay, is not super good. The problem we have here, Sadi, with that case that I really wanted to do is it's not FDA approved and we cannot get it done and nobody will pay for that. The financial problem, that's why this case, it did not go through at all. It did not even go through NYU where they do more ABI. Even NYU, they could not do it because it's not part of any study anymore. So it's a limited number of patients. I really don't know what the future is going to be for that. I really think that there is a difference between putting an electrical current on the nucleus directly versus using the normal pathway that conducts through the inner ear and the cochlear nerve all the way to the nucleus. It's a different fine tuning for the hearing. So
okay.
There are a couple of other questions, and I would like Costas to comment, but Tom Oxley had a question. What are the if what are the indications for the ABI? And Tom, I don't know if you are still here, but if you are, do you have any other thoughts about why this would or would not work? You may need to raise your hand. Sorry. Go ahead, Tom.
Can you hear me?
Yes, sorry.
No, thank you for the talk. This is fascinating. The cochlea is the archetypal neuroprosthesis, which is a space that I'm in now, and I've been studying the cochlear technology so intently, and it's just incredible to hear it in the clinical realm being so effective. I just was interested. I know very little about ABI, and I'm wondering about. It looks like that's a surface electrode of about 16 surface electrodes that goes onto the nerve. I'm just wondering what the indications are, and you mentioned the failure rate. I'm just interested more in some of that detail.
Yeah, sure. So the indication today, at least in the United States, is if patient has a neurofibromatosis type 2, adult with NF2, and what that means basically is a patient who does not have a cochlear nerve, or has a disease that is sitting on the cochlear nerve, or had surgery for a tumor and there is no cochlear nerve. So you have to put the electrode directly on the cochlear nucleus. That's the FDA approval in the US for this specific patient. In the days, which mean in the 90s or the 80s, the largest series came from the house group. And there were like a lot of discrepancy in the outcome. The majority of patients, they don't develop open set word. And it's very hard to understand why some patients do develop, but the number was way less than 10% that they have some open set word. They just can get the noise, and they can get some closed set words in some few patients with NF2. So with time, not a lot of people were very excited about the ABI for that population, because I think there is a lot of other disease in NF2 patients that did not allow to process the sounds well. However, there were some clinical trials that has FDA pre-approval, and it's not yet approved. It's for kids who don't have a cochlear nerve, whether they have an absent cochlear nerve by birth or something by surgery. And there is probably 10 or 15 cases, maybe 30% has open set words, but we did not see from the 3 centers after that in the US. Basically, at that time it was UNC, Los Angeles, and in Boston. We did not see a follow-up on those patients and see how well they do down the road. I know from friends of mine in Italy who in Verona, Coletti was the chair of the department at that time, who was the one who first reported on the kids. He has a good data, which is around 40 to 50% open set, which means they will be able to talk on those kids. But then my close friend now in Verona, who's took over, he said, I'm not sure if that data is very filtered very well. So on kids, the number is very small. It's scattered. In the US, we are not yet approved to do it. You need to have no nerve or a trauma on a kid that lost hearing and their nerves, and then you can be able to do it. But you have to have a specific center. I think that study is stopped. So we're still not going to be able to do it in kids. On adults, NF2 patients, that's very easy. And then you can do it after you take the tumor out at the same setting. But don't expect like a outstanding or an outcome like the cochlear implant even. They just mainly to recognize noise for those patients.
And so must have to do with the translatability of the stimulation in that portion of the nerve compared to the more distal portion.
It. Yeah, that's definitely it. And the other thing, there is a lot of scarring in those patients that I think there are also some technique or technical, the padding of the electrode, there is some of them are 12 and 16, might not have the cover all of the nucleus. And that might be image guidance or new technology will give you better coverage use with that. So
The other recent exciting advance with Cochlea and the FDA has been the approval by the FDA of Cochlea's connectivity software. That is, so that even though it's a class 3 device, Cochlea have drawn a line between where the Bluetooth signal occurs from the delivery of the data to then the device. And what that means is that they've now connected the cochleas directly to iPhones. And the first patient to have their cochlea put straight into the iPhone turned it on, I think, about 12 months ago. And so that's the next phase now, where the cochlea, becomes like a smartphone in your head, I guess.
It's nice. It would be nice if we had a translator, though, that could get that translated into the nucleus, because that's really the problem. Kostas, did you have any questions or comments?
I know George has to get to the hour quickly. Awesome talk, George. Really enjoyed it. The Baha implant is something I feel has gone up and down, and I wanted to get your thoughts, because I know, some patients really like it and dislike it. And what's your approach with that type of implant?
Yeah, so there is the Baha for the cochlear, for the hearing loss completely, which is after an acoustic. You need the percutaneous, which means the screw. You cannot have the magnet, because the magnet does not have enough power to conduct the sound to the other side. The problem putting through in some people will tell you, I don't want to be Frankenstein at all, and some people, I have a spouse when I was in Nashville. She was so happy how cute her husband is with the Frankenstein in his head. So it's crazy how people look at it in a different way. However, like the look matters a lot on the Baha for some patients. Also, there is some skin issue. These are passive implant, Costas. Last year, there's a new set of active implant came out. And one came from, it's called Ossia from Cochlear, and the other is from Bone Bridge from Medel. Both are under the skin and they are active, which means they vibrate. It's not passive, they're strong, and they are magnets. So there is no screw coming out or Frankenstein look. So we were hoping that this will take more indication. The problem, it's not covered by any insurance. So patient will not pay for that. So we will see maybe down the road if this get covered, if we see an uptick on that indication. You have to remember, when we look at a lot of patients and study, no more than 25% of acoustic patients of us wanted to have anything done for them. If you wait a little bit for them until they heal, they just don't want anything. Some people initially put the Baha immediately during surgery, and we felt that we're forcing that on the patients. When we took a step back and asked our patients, no more than 25% decided they want any form of hearing rehab after an acoustic neuroma. So we'll see.
Thank you.
Fascinating. Much more to go. I will observe that a beautiful talk like this that you completed in less than 45 minutes allows for this kind of discussion, which greatly enhances the experience. So thank you for that. And I think we could turn it over to Josh now, because we're going to go from the 8th nerve to the 7th nerve.
Okay, I'm going to share my screen. And I'm going to confirm that you can hear me and see my screen.
Yes. Confirmed.
Okay, so today I'm going to be talking about acoustic neuroma and facial palsy. And really, I'm going to be speaking about the spectrum of facial palsy we see after lateral skull-base surgery, most commonly acoustic neuroma surgery. And the reason why I really want to address the spectrum of facial palsy is, classically, we all think about facial palsy or facial paralysis as that House-Brackman 5 or 6 you see up here, where it's gross asymmetry, poor eye closure, really the whole flaccid paralysis. But for many of our patients, they actually do, even if they have House-Brackman 6 palsy immediately after surgery, do get some degree of recovery, but that recovery can be limited, and it often falls into what we classify as a House-Brackman 3 or 4, or what we might also call a frozen face, where there's chronic spasm and synkinetic movement that prevents them from affecting full facial movement. So you can see above, we have our more classic flaccid type paralysis patient. She has already had a lid loading done. And here we have a patient who's about 2 years out from acoustic neuroma surgery. she recovered, but when she goes to smile, you'll see it coming up here. You see there's all this tension on her lower face. She can't get good lip elevation, and she really does have a lot of asymmetry with animation and with emotion. And these are both disabling conditions for the patients for various reasons. So just a couple notes on facial paralysis in general. Facial paralysis is a severe form of facial disfigurement. Facial expressions are universal. No matter where you are in the world, no matter what language you're speaking, these expressions are almost always understood. And for any of us who've ever traveled to a foreign country, you know, how much a part of what we're emoting on our faces are part of trying to get instructions or trying to communicate to someone whose language we might not speak or has limited ability to speak English or whatever language you might be fluent in. Facial paralysis can lead to significant social and psychological difficulties. So, and these are just some limited studies I'm mentioning here, but this is really widespread and across many different psychological outcome measures: decreased self-esteem, anxiety, depression, social isolation. So these are patients who don't go to work. These are patients who don't go to family dinner, who really have a very limited life and end up really spiraling into depression and other serious issues. In terms of facial palsy and a social disability, when we look at perceived health utility scores, patients will rate it similar to having monoocular blindness. And I think just based on what George was talking about, even just unilateral deafness can be severely disabling. Monocular blindness is obviously severely disabling. And you know, patients will perceive a unilateral facial paralysis to be on the same level of perceived health utility. A couple of the things that we don't always think about, there's also speech impediments. Patients lose the ability to make plosive sounds. I included the video of this gentleman here. One of his favorite hobbies is he has a group of people he sings in a doo-wop group with. Well, try singing anything, especially doo-wop, without making plosive sounds. That's extremely difficult, if not impossible. And like I mentioned, there's decreased social participation. When we look at data, that decreased social participation is comparable with a total laryngectomy. And we all know patients who have had total laryngectomies, they have to speak either through a tracheoesophageal puncture device or an electrolarynx, and also comparable with other head and neck cancer patients. And I know that, you know, this audience might not see some of the severely disabled head and neck cancer patients that we all see, but that is a significant level loss of social participation, and patients with facial paralysis suffer the same thing. In terms of acoustic neuroma, CP angle tumors, and facial paralysis, obviously you all can tell better than me that facial nerve preservation is an essential aspect of surgery, and that tumor size correlates with poor outcome. This is a study from 2004 that looked at about 1,250 patients from Denmark, and they looked at both their outcomes in a variety of ways. But you can see here that based on tumor size, so less than 10 millimeters up to greater than 40 millimeters, white is a good House-Brackman 1 or 2 outcome, and black is House-Brackman 3 through 6. And you can see the larger the tumor size, the worse the outcome. And these are a year plus after surgery. So there's a direct correlation there. One of the things they noted that patients with normal facial nerve before surgery, 70% had a good outcome, which they characterized as a House-Brackman 1 or 2. And about 78% of facial palsy patients who had a 3 to 6 after surgery, they discharged and improved over time, improved after their discharge. Other studies have found similar rates of about 70% will have a House-Brackman at 1 to 2, and then there'll be another 30% with varying degrees of facial palsy. Now, it's important to recognize, and when you look at their data from the Denmark study, among the 30% who had permanent facial paralysis or palsy, the majority of them fell into the House-Brackman 3 to 4 category, where they had spasm and some function, but not enough to really create effective emotion on that side or effective facial movement. Only a few, about 6%, I think, actually fell into having a permanent House-Brackman 5 or 6. And so it's that area in between where we do have treatment options for patients, but they often fall through the cracks or don't fully recognize that they can, really every patient has options. In terms of patient-reported outcomes, there's been some studies looking at the various acoustic neuroma associations. The first one up here was from the American Acoustic Neuroma Association, or the North American one, and they looked at about 1,600 respondents. The second one was the British Acoustic Neuroma Association. They used the FACE scale, which is a disease-specific quality of life measure. If you look here, 45% of patients are reporting some kind of facial palsy after surgery. 72% are reporting permanent loss of function, but only 19% are reporting that they had any lid loading or eyelid surgery. So that's a little bit of a discrepancy to me. It tells me that a lot of patients have mild dysfunction that don't even require that they have a lid loading to help close their eye, but they still consider it dysfunction. About 28% reported that their quality of life was significantly affected, which I think is in line with the other 30% we're seeing from surgeon-reported outcomes. The same pretty much goes for the British study. One thing that was important here was 33% reported no treatment. So that means there's a sizable portion of patients with facial palsy, or what they perceive to be a palsy, who are having no treatment, either by their own decision or lack of available resources. And if you look at the treatment they are having, about 50% are having a lid loading, which we know is appropriate and right for most patients. They need to close their eyes. But then the other stuff is a little vague. 41% are having electrical stimulation, which I'll address later and really doesn't have much evidence, if any. 39% are having physical therapy, which can be beneficial if done correctly, but that's hard to find. And then 12% are listed as having a nerve graft. I'm not sure if that means nerve graft at the time of surgery or nerve transfer procedures after the fact. But 12% is not a high yield of patients who have potential problems engaging with potential treatment possibilities. The other thing I think that points out from all this data is there is a little bit of a discrepancy between what us surgeons are seeing, what we consider to be facial palsy, or what we consider to be something that would affect the quality of patient's life, and what patients think affects the quality of their lives. So a lot of this is patient driven. We might see a House-Brackman too, which is basically symmetric at rest, asymmetry with movement, complete eye closure, and probably some synkinetic movement. We might think that's great because we're seeing patients who have severe flaccid paralysis that can't even move the side of their face years out from surgery, but the patient who has that problem doesn't think it's so great. And just to give you an idea, this is what a House-Brackman 2 looks like. This gentleman has good symmetry at rest, and when he goes to smile, his whole face is in spasm, can't affect a good smile. And to him, you know, he's in a sales field or any field where you're interacting with people, both socially and at work, that can be quite disabling. So this is one reason why patients will often report higher rates of facial palsy or disability than surgeons might report after when looking at surgical outcomes. So when do we intervene for patients with facial palsy after acoustic neuroma surgery or other lateral skull-based surgery? So there's a strong consensus for early eye intervention. Any patient who can't close their eye and can't maintain good eye hygiene needs to have eye intervention. And I'll explain to you what the classic eye intervention is in a couple minutes. It's time tested and it's data proven. The timing of nerve re-exploration and potential re-innervation procedures such as nerve transfers, that's less clear. Because we know that when patients leave the hospital, even if they have a House-Brackman 6 or 5, we know that many of them will recover. We just saw that data, or we'll get some recovery. So our goal is to figure out who's not going to recover well, or who is not going to have enough recovery that a nerve transfer or other reinnervation procedure wouldn't make them better than leaving them alone. We also know that that recovery is going to happen really in the first year. But at the same time, we finally know that when we intervene, when we do nerve transfers or other reinnervation procedures early, we get the better outcomes. So we're kind of in this race against time to figure out how soon are they going to recover, and if they're not recovering, how soon can we intervene? And it's a little bit of a guessing game. There's no standard test. So the other thing to keep in mind is patients will get recover. We can do reinnervation procedures from 0 to 2 years after surgery, but really between 0 and 1 year is the best. But after 2 years, there's no meaningful chance that a nerve transfer procedure like a cranial 7 to cranial nerve 12 transfer will give them any benefit. Further evidence, there is some evidence that suggests that patients who are really having no meaningful recovery from their time of surgery to 6 months after surgery, that's a poor predictor. And most of those, the overwhelming majority of those patients will not get any meaningful recovery or recovery that wouldn't be better than what we could do for them by doing other interventions like, again, nerve transfers and a variety of other things I'm going to talk about. I typically get, for these patients, get EMGs. I'll get it at about 1 to 3 months after surgery, and then between 4 to 6 months, just to track and see if there's any benefit. I find EMGs they don't always clarify the picture. Oftentimes they just give you information that you already had, that the patient has a facial palsy of some kind. But one thing I really try to press the neurologist on is, do they think there's an intact nerve? Do they see conduction coming through that nerve? Because sometimes they can tell you there's really nothing coming through, and then you know you can act earlier. You've kind of gotten permission to move ahead with your other planned surgeries. For patients who have chronic facial spasm, those patients who have that House-Brackman 3 and 4 type scenario, they have, or even House-Brackman 2, and they have incomplete facial nerve function, there are many treatment options for these patients, and that's not often recognized. And there's no time limit for these patients. So those patients can be 10 or 20 years out of treatment or out of surgery, have chronic spasm, and there's still things we can do for them. So I'm going to do this through 2 cases. I labeled them scenarios because I don't want you to think of this as one patient, but as a amalgam of typical patients you'll see. And this is a patient with a flaccid paralysis. You can see here she had a lid loading already, and we've also done a cranial nerve 12 to 7. But we know that most of the time that cranial nerve 12 to 7 transfer is not going to get her a full smile. It will help with her facial tone and eye closure. So this is her before we've done anything else to address her smile. And this is that classic House-Brackman 5-6 patient, what we call flaccid paralysis. So if you look here, this is a big treatment algorithm of all the different things we can do. And the arrows go both ways because patients may move between these areas. They might start with a flaccid paralysis. We do intervention. We do varying parts of smile or eye surgery. They get recovery, but then they're getting some spasms, so they go to physical therapy. But you can see here, there's a huge number of options available, and you have to figure out where you're going to put the patient on this pathway. I always emphasize to patients that it's not one surgery. It's not one physical therapy session. It's not one injection of Botox. This is a continuum of care that's going to happen over the course of their lives, and they can engage with it when they're ready and in ways they want. I do also always warn them about expectations, and we'll talk about that a little bit at the end. So let's start with the brow lid complex. Eye closure is the most important part of facial nerve function, specifically because with incomplete eye closure, we can get corneal abrasions, chronic keratopathy of the cornea, and finally blindness, and it can be extremely painful for patients too. So the classic procedures and the most evidence-driven procedures for eye closure really may remain quite standard over probably 20 to 40 years now, which is a lid loading with a weight, and then a canthoplasty or some kind of lower lid tightening procedure. Attempts at reinnervation, although they're in the literature, they've not been widely replicated, and other than doing the nerve transfers, I'm talking about direct reinnervation of the eyelid, let's say a cross-face nerve transfer, are not widely used. So we typically use a platinum weight, not a gold weight. Platinum weights have some evidence for lower extrusion rates and less corneal astigmatism. The gold will mold, or all weights will mold the cornea over time, and the platinum does a better job of doing less of that. We implant in the eyelid. You can see here it's at the lid margin. We typically implant it a little higher up. About half of it will be over the tarsal plate. The other half will be the orbital septum. That will help prevent it from extruding through the lower eyelid, which you can see after many years of having it in. And it also makes it more cosmetically appealing. You can see it's barely noticeable here. And this is a patient after her lid loading. Now, lid loading is not the same as having a spontaneous blink. It doesn't work as quickly, and it does take a little more time for it to close. You can see when her eye closes, there's a lag there, and patients do need to be instructed. They're also probably not going to get 100% eye closure. Typically, we're satisfied with 90% or above, especially when that's coupled with a good Bell's phenomenon, because then we know that they're protecting their cornea. Patients that we really want to intervene early on, again, I can't emphasize this enough, are patients who are not maintaining good eye hygiene, so they're coming in with scratched corneas and erythematous eyes, and also patients who have insensate corneas. Those patients, they don't know to protect their eye, and they can't feel the damage they're doing to it. You can see here, this is a gentleman who couldn't protect his eye. He's got a partial tesorophine to help protect it. And here he is after surgery, he can get almost complete eye closure. And so that's a big difference maker for him. Reinnervation procedures. So patients who have a facial paralysis after surgery, those that we don't think are going to get or aren't getting any recovery, one of the best things we can do for them is try to get new innervation to the facial nerve. That won't always affect a good smile, but it will provide them better facial tone, which will lead to better cosmesis, and will also help give them better eye closure and more of a blink. And the two classic facial nerve transfer procedures are the cranial nerve 12 to 7, and you can see here, this is the left side. So here's the hypoglossal nerve. Here's the main trunk of the facial nerve after it's left the skull base coming into the parotid. You can see the pes here, and here's a cable graft between the two. We don't cut the full thickness of the hypoglossal nerve. We typically cut halfway in, expose enough fascicular bundles for us to feel comfortable with, and then we connect the cable graft to the facial nerve. You can do this without cable grafting, but typically it involves a significant amount of mobilization of the facial nerve, and most people just use a cable graft at this point. It's been shown to be very effective. The other facial nerve transfer procedure, the other donor motor nerve in the face, is the masseteric branch of cranial nerve 5. And you can see it leaving here, the sigmoid notch, and coming to the masseter muscle. You basically have to dig through the masseter muscle into the deep belly of it, and you can identify it's a very small nerve, but can be quite powerful. And you can see here, this is a patient who had a 5 to 7 transfer. This is before, and we'll transfer over here, and you'll see she's got better tone and a little bit of a better smile, blinks better, but the smile itself is okay. It's nothing to write home about. And so our goal is to get a little more than that. But she is getting some lip elevation and dental show. So those nerve transfer procedures alone can make a big difference in the quality of patients' lives, but oftentimes we want to then move towards what we can do specifically for smiles. So smile surgery can involve a variety of things. Sometimes we do nerve transfers alone and do get an adequate smile, but especially in patients who are a little bit older, that tends not to happen. And I'm talking about patients really in their 40s and 50s, not in their 70s or 80s. So we typically will do some kind of muscle transfer for smile reanimation. The two classic ones are temporalis muscle, and here's a picture of us doing a temporalis tendon transfer via the melolabial crease on a patient. The other one is a gracilis free muscle transfer, where we're doing a free gracilis muscle flap and reinnervating that flap with either a cross-face nerve graft or the masseteric branch of cranial nerve 5, or both, which we're doing more commonly now. So looking at a pedicled muscle transfer, the temporalis or temporalis tendon transfer is really the classic procedure, and they're quite effective. They're great, especially for older patients who we know that the outcomes from gracilis-free muscle transfer usually aren't that strong. They're also good for patients who aren't ready for many hours of surgery and aren't ready for the recovery that might entail. And you can see the significant difference here. You know, this is a patient here, this gentleman, he looks angry. He looks like the unhappy neighbor, the guy you see on the street and avoid, someone who had a stroke. He looks disabled. And this patient here has a lot more symmetry and is someone that people are socially more comfortable dealing with, and he's more comfortable with himself. The procedure itself is very quick. It can take anywhere from 1.5 to 2.5 hours, maybe even less if you're very facile. You make an incision in the melolabial crease. One of the reasons why this is great for older patients is they often have deeper melolabial creases to hide that incision in. Via the buccal fat pad, you access the coronoid process with the attached temporalis tendon. You just cut off the coronoid process, and then you swing the whole thing forward and attach it to the orbicularis muscle. And it does work well. The amount of lip excursion you can get from this can be limited. It can be difficult to get a significant amount of lip excursion. But let me show you here another patient who had this. It's before. And then you can see after, when he clenches his jaw, he's able to get a little bit of lip excursion. It's not dramatic, but it does give him better symmetry. The other option, which we really prefer to do for patients, especially younger patients, patients who are basically under 65 or maybe even under 70 now, is a free muscle transfer. The classic description of that, the first surgery is a cross-face nerve graft from one of the redundant buccal branches from the contralateral facial nerve. You wait about 6 months for that nerve graft to be innervated. And then you do the stage 2, which is the free muscle flap. And then stage 3 would be some kind of refinement. And then about a year to a year and a half after surgery, after all this began, they start to smile. There are many variations on this, and we're starting to do this in one stage so that we're not dragging this process on, especially for patients who've already been on the operating table for many other reasons and are starting to have some kind of exhaustion from having surgery, just personal level. So this is, again, our patient before free muscle surgery, and you can see here, she's really not going to get much lip movement. Her eye closure is not bad, but when she goes to smile, there's really nothing happening here. So for her, she had a classic 2-stage procedure. She had the brow and eyes, which were done before, and a cross-face nerve graft. And you can see here, we harvest that endoscopically. So it's about a 1 to 1.5 centimeter incision right lateral to the lateral malleolus in the ankle. And we're able to get a long length of sural nerve up to 25 to even sometimes 30 millimeters all the way up to the popliteal fossa. So it's elegant, it's a small incision. The patients are left with a little numbness on the lateral foot. Sometimes they do have some neuropathic pain after surgery, but that typically subsides with either over time. So pull back individually. Hold on a second there. Let's get rid of that sound. So here's her during her gracilis free muscle flap. We've put the sutures in that we're going to anchor this to along the modiolus, along the orbicularis, and where the orbicularis connects with the normal zygomaticus muscle. The gracilis flap itself is quite small. It's a small sheath of muscle that's innervated with the obturator nerve and then the artery and vein here. The artery and vein gets connected here to the facial artery and vein, and then the nerve is brought into the mouth where we've hidden or buried or banked the cross-face nerve graft and the ipsilateral canine fossa. And you can see again, here's before surgery, and then here early results about five or so months after surgery. And here she's about 1.5 years after surgery. So she's able to get lip elevation and a more symmetric smile. Again, and this comes down to expectations. The key thing whenever I meet any patients, whether they have a House-Brackman 2 with a lot of spasm that's bothering them, or whether they have a House-Brackman 6 with no movement whatsoever, is we can help you, but we're never going to get you back to the perfect symmetry with the opposite side. We can do a lot, but we can't recreate that perfect interaction between nerve and muscle that gives you your natural facial symmetry. And manage those expectations is really important for patients. So the other thing is we can also do these bilaterally, and we do see patients from time to time who haven't had great access to care and have a variety of other things. So this is a 55-year-old woman with Mobius syndrome. It's very rare to see a patient this old, and she grew up in New York City, so it wasn't like she was nowhere near hospitals that did any of these major reconstructive surgeries, but she was left her whole life without having anything to address her face. And so she ended up getting a brow lift. This is her before anything. She ended up getting a brow lift, eyelid weights, and you can see here, and then bilateral gracilis free muscle transfers that were innervated solely off the masseteric branch of cranial nerve 5. Here she's about 6 months out from the left side and 3 months out from the right side. One thing I like about using cranial nerve 5 as a donor nerve, as a motor donor nerve for the gracilis is they tend to reinnervate quite quickly. It's a much shorter distance to travel. And so nowadays, even for our patients who are having unilateral gracilis free muscle transfers, we will double innervate those with both a cross-face nerve graft and the masseteric branch of cranial nerve to try to get them the maximal amount of movement and the maximal amount of reinnervation. So scenario 2 is this spasmatic paralysis or poor smile elevation. And I apologize for a little bit of the blurry video, but her case is a good example. So she had an acoustic neuroma surgery about 2 years before I met her. And you can see she's got some asymmetry and she does have some movement. And again, watch when she smiles or moves her face, she's able to get some lip elevation. She's got a lot of spasm on the lower part of the face, and she can't really affect great smile movement on that side. And again, you know, we see a lot of highly disabled patients. So this doesn't always seem like the biggest deal to us, but, you know, imagine taking pictures at your family events, your kids' weddings, or, you know, bar mitzvahs or communions, and you constantly look, you know, off center like you may have had a stroke, and it can be very disabling and disfiguring for patients. So facial movement, and one of the reasons why we see patients like this is facial movement is a complex set of coordinated maneuvers, right? It's not just one muscle contraction. Like every other maneuver in the body, whenever you go to smile, certain muscles are contracting while other muscles relax. So we have the zygomaticus, the lip levators, the risorius that are contracting when we go to smile. We have the depressor anguli oris that's typically relaxing when we go to smile. And then we have the DLI that will contract or may contract in varying degrees depending on depending on the type of smile you have, and there can be various types of smiles in patients. And so for patients who've had facial nerve injuries, whether it's a Bell's palsy or lateral skull-base surgery where there was some traction or insult to the nerve, they can recover over time, but for a variety of reasons, that recovery, like most peripheral nerve injuries you see all over the body, can be characterized by limited movement and chronic spasm. And that chronic spasm can be a significant issue because typically when these patients go to smile, they get contraction of all the typical muscle groups that are supposed to contract. That contraction is no longer strong. But at the same time, there's still the DAO and the platysma are also contracting. So while they're having a limited ability to raise or smile, they're also fighting that with the muscles that are supposed to relax. It's all firing at once. And that's a mix of cross-innervation, changes in the motor end plates, chronic changes in the motor end plates, and then chronic changes in both the basal innervation of those muscles and so on. So for these patients, it's really a multifaceted treatment approach. And that treatment involves three main things: physical therapy or facial retraining. And I'll go through the difference between, going to your regular physical therapist and going to someone who's knowledgeable about this. Botox or neurotoxin treatment. And then there's a variety of surgeries that in recent years, we've seen better evidence have worked and given patients really superior results compared to what we used to do for these patients. So in terms of physical therapy and facial retraining, most patients and most physical therapists are totally unaware of how to do this kind of work. And most patients come to my office telling me that they went to a physical therapist and they went and got a massage 3 times a week, which was nice for them, but didn't really do them any good. And so there are a select number of physical therapists in the country who are very well versed in facial retraining. We're very lucky in New York, we actually have one of them who lives here, and she's fantastic. In terms of the evidence that this works, well, the point of facial retraining is to help patients understand the movement on their face, the movement they have, and then make them aware of how they're moving their face at certain times. And also train them that, going forward, they may have to make a more limited smile in pictures. They might not be able to make that broad toothy smile anymore, but they can create a smile that's more symmetric and that does show good emotion. When you look at the evidence and what people who are well-versed in facial training do, and there's a good Cochrane review on facial retraining after Bell's palsy, after chronic spasm after Bell's palsy, there is evidence of benefit, but the studies themselves are not high quality. There's no large randomized prospective trials on this. Biofeedback is really the key technique. And the classic biofeedback method is just using the mirror. And patients see the physical therapist, and then they're trained to do certain exercises and to learn how to identify and recognize their facial movements through mirror training. One of the key things here is patients often come in with an electrical stimulation device, a TENS device. There is no evidence that this works, and there is some evidence that it actually makes spasm worse. But it is a classic thing that patients are offered both by physical therapists, by neurologists. It's just not well understood that this is not an appropriate therapy and doesn't do anything for the patients. The other thing that I think it's really important to emphasize with patients is this is not like, I had knee surgery, I'm going to go for 3 months of physical therapy, and then I'm going to get back on the basketball court. This is a peripheral nerve injury, which takes years of rehabilitation. And these exercises, if they want to get the most benefit, are going to become part of their daily regimen for years to come, and they will see improvement. The improvement is not perfect symmetry the other side, but it can be a significant reduction in the amount of spasm they have, their degree of comfort, and their ability to create facial emotion. Next, we couple that with Botox, and Botox is, and Botox is a brand name. It's really injectable neurotoxin, for which there's many brands now, but Botox is widely recognized and widely used. So please excuse me using this brand name. But injectable neurotoxins or Botox can really do a great job helping take some of the chronic spasm that we see, targeting some of those muscles, helping them relax and helping the patient affect better facial movement and improve comfort. So we take a zonal approach. We look at the brow and forehead region, the periocular region, the midface and perioral region, the neck, all separately, and target them with individual doses or with specific doses of Botox. And you can see here, what we're really going after is this patient here. She's got a lot of spasm here. She's got a narrowed eye. The corner of her mouth is pulled up in a little bit of a funny area. And here you can see she's just a little more relaxed. So again, these are not going to dramatically alter or give her perfect symmetry, but it's going to give her a slight improvement. And that margin can be all the difference. We have a couple of different, you can see just a video of us injecting her. And typically we're injecting anywhere from 10 to 20 units around the brow, 10 to 20 units around each eye, usually about 10 units around each eye. The DAO typically gets a big injection. The mentalis and the platysma get a fair amount. We may also target the buccinator. The buccinator does play a role, is innervated by the facial nerve and plays a role both in an inability to smile and also the sucking in of the gum of the buccal mucosa and chronic biting that patients have when they have spasm there. And then depending on the patient, we may also inject their contralateral DLI so that they don't pull down their lip on the other side when they're smiling, just to help create a more symmetric smile. And you can see here, with all her emotions, she's now much more relaxed. Typically, when she used to close her eye, you'd see the whole corner of her mouth would pull down, the platysma would contract. Here, it's much more normal. Same thing when she pursed her lips. Here, she's getting a nicer smile. This is her trying to smile before. You see everything's being pulled down. Here, she can get a nice close-up smile. Again, it's typically not a large toothy grin, but it is able to show emotion. And the patients are typically much more comfortable with this. And there's a fair amount of data now. There's no great prospective trial on this, but there's a fair amount of retrospective data and other quality data that has shown that patients improve both on our reported outcomes and also patient-specific quality of life outcomes using Botox therapy. So it's widely accepted and we encourage it for patients. Patients are redosed every 3 to 4 months. Some of those patients, you know, at first when you tell them they're going to come see every 3 to 4 months, it sounds like a lot. I try to phrase it as three or four times a year, which is a little bit, I think sounds a little bit like a little smaller amount of time they'll be spending at the doctor's office. Finally, there's surgery. So one of the things about surgery for these kind of patients, these House-Brackman 2 to 4 patients, is that it's really all over the map. Every 4 years, there's a large international meeting of facial nerve, a large international facial symposium, which draws people from all over the world talking about the management of facial paralysis. And whenever I go to this meeting, people are presenting on everything they do for these kind of patients, these spasm, synkinesis, frozen face patients. And there's everything from massive amounts of Botox to, there was one presentation on someone who removed basically almost all the facial muscles on one side. And generally the results are, there's nothing special. It's a little bit of like a where's the beef moment when you look at the results. And so really it's been all over the map. Over the past couple of years, the procedure that's really become most popular and does have better data behind it is what we call selective neurectomy. And so what we do is we do a typical facelift approach, and then we elevate the SMAS here. And I'm not going to get too far into the facial anatomy, but all the distal nerve branches are sitting beneath the SMAS. And we're able to trace out and identify all of these small facial nerve branches. And we're literally, you can see us here, stimulating each one of them individually. We're stimulating which ones do lip elevation, which ones just do the DAO. If we can trace out an individual branch of the DAO, that's great. Which ones do the mentalis, the DLI, and the platysma. And so we're identifying all these separately. And then the ones that do the DAO, the depressor anguli oris, the platysma, and all contraction in the lower part of the face, except for we try to maintain the DLI branch, we then cut them, clip them off, and try to de-innervate that area because we know it's not benefiting the patient at all. And typically we were just using Botox to do that anyway. So now we're trying to make that permanent. The landmark publication of this was in 2009 by one of my colleagues in LA. And 75% of patients saw significant improvements in both their SPAS and their smile vectors, both objective ratings like the FGS scale and also disease-specific quality of life outcomes. Many times we'll couple this with a cranial nerve 5 to 7 transfer, and that's where we will take the masseter branch of cranial nerve 5 and connect it to one of the buccal branches, just to help to get, not to take out the whole facial nerve, but just try to get a little more power to the smile elevation. And it can have really impressive results. You can see here, this is the same patient after we did a neurectomy and a cranial nerve 5. Oh, get that playing there. And you'll see she's really able to get lip elevation here and get dental show. Again, this is not perfect symmetry, right? And we always want to emphasize that with patients, but it's a significant difference from where she was. And she's really able to get a lot more out of that.
Dr. Rosenberg, I just want to give you a 2-minute warning so we have time for questions.
All right, I got 1 more minute to go. Finally, there's adjunctive procedures. Endoscopes, they're not just for skull-based surgery. So brow lifting, face lifting, blepharoplasty, these are all key parts of helping patients achieve facial balance. A classic look here is brow is slightly down, the upper eyelid is hooded compared to the other side. For these patients, they get an endoscopic brow lift, which you can see pictured here in a blepharoplasty, and we're able to get them much better facial symmetry. So all of these options are out there for patients. So as we talked about, facial paralysis is a severe form of facial disfigurement, has a wide variety of presentations, and there's a wide variety of treatment options. I cannot emphasize enough that every patient can benefit from treatment. So anyone who is concerned should be referred, and there are things we can do for them. Thanks. Questions?
Great, thank you very much. Josh, can you unshare your screen, please?
Definitely.
That was really, really good. And I just want to, it was so good that I just want to share this. Can you see my screen now?
Yes.
For attendees, we're going to start posting these. This is a link to all of our grand rounds that we've had that Dr. Kellner has been recording. Right now, this is on his YouTube channel, and we're in the process of creating our own YouTube channel for neurosurgery. As these lectures begin to develop a legacy, we're going to have quite a library here. So we will be posting this and letting people know about it. There are a couple of questions that I have and other people may have. The seventh nerve palsy, we focus on lid closure and the smile. Another important function is eye opening. And every now and then we get a third nerve palsy or some sort of nuclear problem that is equivalent to blindness in a patient who has vision. You've shown that you can do slings to raise the lip. Is there a sling that you can do to raise the lid? Or is there something else that can be done for that?
There's a classic ptosis repair where you're shortening the levator aponeurosis, which can be beneficial for patients. Typically that will be a big benefit for them. There are some typically not for cranial nerve 3, but there are some eye reinnervation procedures. And I didn't picture it here, but for patients with insensate eyes, we've begun doing corneal reinnervations where we pedicle it off the contralateral V1, and we have seen some benefit from those patients. One thing that does come up is they still don't protect their eye wall, some of them. So now their eye just hurts because they can feel it again. But we are looking at a variety of ways to create reinnervation for all aspects of the orbit.
What about 3? Does anyone else have any comments or experience in getting the eyelid open again? Anyone in the audience? The most effective thing that I have seen is a prosthesis that is a clip that fits to the back of the eyeglasses and is a spring-loaded clip that pushes the eyelid open, and they're able to close it when they have good seventh nerve function. But the third nerve palsy is perhaps the most devastating one, particularly when the eyelid is closed, the ptosis.
I guess
The only problem with that, Josh, is that usually with the third nerve, when they open the eye, they get diplopia as well. So I always looked at the eye closure as being a gift. When they had the third nerve, whether it was complete or even partial.
For unilateral, that is true, but for whatever reason, maybe just because we're getting more and more difficult cases, we have had a large number now of patients with unilateral blindness presenting with blindness progression or some other problem on the one remaining eye. And we'll have to review this, but I think between Raj and I and others, we probably have half a dozen patients now who present with already blind in one eye, who are then developing a third in the other eye. And it's a really vexing problem. Any other questions for Josh?
I just make a comment, I think, for residents particularly. We often look at these patients and we say, oh, grade 2, they're really terrific, or grade 3, they function very well. But the subtleties of how it affects the patients is not seen till later down the road. And I think all of these techniques are spectacular again, and they get better all the time. And having this expertise is a gift, but one has to remember to refer the patients with the mild changes to get them even better. And terrific talk, Josh.
Thank you.
I have a quick question if we have time.
Yeah, go ahead, Peter.
So I wanted to ask you, we have these children with brainstem tumors, like dorsally exophytic low-grade brainstem tumors. We expect them to live a long time. And every once in a while, we have a nerve injury in the brainstem. And so they end up with a complete or near complete facial palsy. How do you view these as candidates for surgery, young children, adolescents?
So I lost you a little bit there, but I think it was about how do you do these kind of surgeries for young children and adolescents. And basically, it's the same set of procedures. So we typically wait until they're between 6 to 8 years old. Before that's a little bit young. And then we are able to do basically free muscle transfers, nerve transfers, and they do really well. The younger patients, they heal more robustly, and their reinnervation's better, and they're also neuroplasticity's better. So for instance, when we're doing mesenteric nerve transfers as part of Richter-Stillis flap for a 55 to 65-year-old patient, they're not going to suddenly remap themselves and know to bite every time they smile. That's a conscious effort that takes a long time to learn with a lot of coaching in the office or facial retraining therapy. Whereas kids, they adapt very quickly. So they do very well with this.
Great, thank you.
I couldn't agree more with what Dr. Post said. Having Josh as a resource is unique. What's also interesting to see how you have developed since you arrived. There's no question that your armamentarium has grown as your personal experience has grown, and we make use of this, and our patients really benefit. I know I recognized one or two of the patients there that you showed. Leslie, do you have any comments you want to make about how your patients respond to this?
Hi, can you guys hear me okay?
Uh-huh.
Mm-hmm. Yeah, I mean, I'll just echo what what Dr. Rosenberg was saying. These patients can go through absolutely devastating, weakness or even paralysis before surgery or even after surgery. And they are so grateful, obviously, that the tumor's been removed or whatever we did, but it really comes down to their face. That's what they really, that's what they care about. We're currently treating a woman who's had an aggressive tumor, a recurrence of that tumor. And throughout this whole process, the only thing she wants done is for her face corrected. Simple things, little simple tricks while patients are waiting for surgery help, like putting the cotton, that roll of cotton above the upper lip. People come up with all sorts of interesting tricks and things just to make them look even slightly better on a Zoom video. So I think this is probably one of the most important talks that we've had.
Great, thank you. Yeah, that new that trick, who gave that trick to us? Was that the mayor?
Yeah, that was the mayor.
So we treated a mayor who was out in public all the time. He had a fairly significant facial weakness that has improved. And what he discovered was taking basically a cotton ball and putting it under the upper lip restored a significant, like a crazy amount of facial symmetry. And I think he stopped doing that now, but it was just a little trick that he developed so we could get out there and, stump on the campaign trail.
He also mentioned, because I know exactly what we're speaking about, that it also helped him speak better too. That it helped him create better lip-related speech sounds, which I think was a big benefit to him.
Yeah.
I just have a quick question for Josh. So first of all, Josh, thank you for all your help. I mean, it's every time I see the complexity of the repairs you do, makes me feel like I have to atone for all these patients I send you. But I'm always intrigued by the anastomosis with the 12th nerve. It's such a fine cut that you do. And I know it's based on judgment and so forth. But do you ever see people actually have over too much tone or tongue atrophy after? Because it feels like that's such a delicate cut.
So the classic problem is that they have tongue atrophy. Typically, what I've seen is that patients who we preserve about half the nerve don't have a significant amount of tongue atrophy. They will have a little bit, and they have almost fully intact tongue function within a couple months. Unfortunately, it's just gestalt, right? You just have to make it. Good thing is we're under a microscope, so at least it looks big. But the 12th nerve, for many years, a little bit went out of style. People would be, thinking that it gives too much mass movement or too much mass facial movement, but it really gives great facial tone and especially helps patients get back some blink, because the eyelid weight early on is great, but when they get back a little tone around the eye, it can make a big difference for both how they look and how they're able to protect their eye and their comfort level. Some patients get a great smile out of it too, but it's not that common.
Yeah. It's just great. That's awesome.
Yeah. Well, these sort of collaborations and talks just emphasize why being part of a health system with really great partner departments makes all the difference in the world. So thank you both. It's a wonderful, wonderful session. We're going to turn now to Raj. Raj, you can hear your screen.
So I'm just going to introduce Susie. I'm sure over the course of the last few months, hopefully many of you have met Susie. She's our new director of OR operations. She just started, and then of course the COVID pandemic happened, but then now she's back. And the context of what we're going to talk about just very briefly is approximately a year ago, we had an unprecedented number of cranial infections. And I think that's led to a lot of work with infection control. We had an external audit done by J&J here. And what we wanted to do with our working group is to try to develop, I call it not even best practice, but better practices to try to distill down what is really, I think, actionable and things we can implement in a way that's going to improve all of us globally as a department. I think this timing of getting back to our practice in the post-COVID era, hopefully, is the perfect time to start to implement these. And also, I think a lot of this flows kind of organically from the types of things we wanted to do. So Susie's really spearheaded this, and Ian, our chief resident, has worked on it. So I'll let Susie talk and discuss. So thank you, Susie.
Can you guys hear me?
Yes, we do.
Okay. I was wondering if Dr. Kellner was able to pull up my PowerPoint. If not, I can share my screen.
Yep, no problem.
Okay. Oh, you can see my screen, right?
That's mine actually, but you can.
Oh, sorry. Okay, no, go ahead. That's fine.
I'll slide share for you.
Okay, thank you. All right. So this is the topic of today's talk is post-COVID best practice guidelines in return of full OR capacity. That on the first slide has my number and my my name, so you can reach me at any time if you have any concerns. So this is the agenda for today. I'll basically introduce myself. I think Dr. Shrivas already pretty much did my part. I'm just gonna tell you my main role in this work in progress position is basically optimization, quality improvement, and standardization of systems, which are found to have a positive impact on quality of care. And then with that, I will discuss about some of the best practice proposals that we are working on for the past month that will affect all surgical stages for our cases. Next slide. I think we can go past those next two slides, Dr. Kellner, sorry. So the first part, before I begin this talk, the best practices, I would like to quote Dr. Ian McNeil, one of our chief residents, quote that I pulled from his presentation 3 years ago, that surgical site infection prevention requires system-wide effort and attention, as any surgical site infection suggests a potential system failure. I will go according to this model in my career here at Mount Sinai. So any infection for me is going to be basically a root cause analysis, and I'll work on it to see if we can prevent any future ones. With that being said, we'll go with the first part, which is pre-op bundle. So one of the things that we're proposing, and as you already know, we had some internal audits from our infection prevention team, and also we actually hired an outside company for a review by J&J. And some of the things were, like Dr. Shrivastava mentioned, are actionable recommendations. And one of them was the MRSA and MSSA screen protocol. Even though research has shown that MRSA, MSSA pre-screening and treatment pre-op can affect orthopedic cases and spinal cases, we're going to generalize it and have this be tested for all our patients. And potentially, maybe the results will have a positive effect on our cranial or endoscopic surgeries as well. We're trying to implement this with the COVID testing right now, since they have a pre-screening as well as a mandatory 48 to 72 hours pre-test. We're going to try to see if we can have that added to that protocol. So if telehealth and office visit, or if telehealth is slowly going to be minimized and providers are going to see patients in the office, hopefully this will be done on their office visit when they're scheduled for surgery. But in the interim, we're in the process of adding this to our COVID testing day. Next, that is the test that if you're planning to do it in the office, these supplies will be arranged to be sent to all our neurosurgeons' office. This test is easily orderable on Epic, and that is the order number for that test. The next part of this bundle was also chlorhexidine wash. We will instruct patient to wash the night before the surgery and the morning of surgery. When reach GP2 has already been arranged to hand out chlorhexidine wipes. They will be given that for the whole body wash while the nurse are assessing them. So that will be like a final wash pre-OR. MRSA and MSSA does have an effect on what we're going to prescribe intra-op. If they're MRSA positive, this will dictate that vancomycin will have to be given 2 hours before within the surgery time, pre-incision time. So that's why it's very useful in our management of their care. There will be pre-op bundles to basically for us to track these protocols that I just mentioned before. Next is the OR intra-op surgical stage. OR huddle, I know we have been doing this pre-COVID, and we just want to reiterate that this will still be in play. This is a huddle that needs to be done with the patient by all the surgical staff. We will have to run through the blue part of this checklist, and hopefully we are able to confirm the patient, document review, and also discuss any intra-op and post-op needs. For intra-op, another part that we want to standardize is actually the skin prep. Different surgeons have different practices. One of the things that we mentioned, we actually came up with, is that we'll try to have the hair clipped pre-OR. I think the resident room already have their own clipper. And if they're inpatients, they will be clipped on the floor. If there are ambulatory patients or DAS patients, they will be coming to our holding, and that's where the clipping will occur. For cranie cases and spine cases on the above the neck, we will be doing a betadine scrub and prep. We will no longer use a gel prep. And for spine cases below the neck, we'll be doing the chlorhexidine scrub followed by chlorhexidine prep. We have reviewed the intraoperative antibiotics recommendation of our infection prevention team, and this is the protocol that they came up with that will be tracked. We will also audit whether we're compliant with these recommendations and whether the redosing is also compliant. So if you're wondering when you give vancomycin, there is also a protocol for that, guidelines for that. If, like I said before, if MRSA is positive, we will have to give vancomycin during the case. Next slide. And also in the previous slide before, there was also plus or minus gentamicin. If there are any increased risks that you're worried about gram-negative infections, like cases over 4 hours or BMI over 30, then you may consider adding gentamicin to your regimen. We will also create an intraoperative bundle that our circulating nurse will track whether the time that our antibiotics were given, the first one, and whether it was redosed appropriately. That'll be the 3 hour, 4 hours, the redosing period that will be part of the protocol. Hand hygiene is we've been doing very well with our hand hygienes. There are hand sanitizers at all entrances of our OR. I've noticed the staffs are been hand washing in and out of the room. But one of the things that it was mentioned is that scrub staff should double glove, and they should remove their outer glove after draping, before handling of implants, and also prior to closure after irrigation. So that's another best practice that we're recommending. Environment, a lot of foot traffic in and out of our ORs, a lot of visitors. We're a learning hospital. A lot of students want to observe and talk to their attending, and basically for communication purposes. We try to institute a closed circuit HIPAA compliant observation deck. We'll be working with Lucy Duffy on setting that up on Annabelle 8 for viewing of our cases. So the OR will be only for critical staff, and hopefully that will decrease our traffic in and out of the OR. And proper attire, these are all one of them decided recommendation as well. If your shoe is designated for OR, then you probably do not need to use the shoe cover as well. Next. I'll be also working with the nurse educator and the anesthesiologist, Dr. Torrey, regarding their recommendations from J&J, and that is a work in progress right now. Post-op bundle, we will recommend to continue the IV antibiotics for 24 hours after surgery, hand hygienes before dressing changes, and wound checks, and see how we can trend this and when we can find, just to make sure that everything is all standard protocol, hand hygiene, and also tracking and documenting the wound when you check them in 2 to 6 weeks post-op. Of course, all these are all recommendations. We need to make sure it's sustainable and that it's compliant. So we will be doing auditing of our practice and present it quarterly just to make sure we are getting towards our goal. So another part of my job or my duty is to track some of the OR metrics that are set by the hospital. First one is the first case on-time start. Given the pattern of last year pre-COVID, we have been averaging around 64%. Of course, the goal is just a preset goal. I think we can do much better. If we've shown to do much better post-COVID, we've been hitting past 80%. So thank you all for that. But they will officially start tracking our OR first case starts soon, given that elective cases are starting or started. Sources of delay are listed here. We will be working with different departments, GP2, SPD, equipment, to make sure that we can minimize these as the cause of the delay. Turnover time is another metric that they've been tracking. And our average has been 67 minutes, but this is a very altered or screwed result, given that some of these times, if they're very, the outliers are all taken out, so that this is not a representative time, but we will be also having a measurement of that as well. Most of the issues that are causing our turnover time to be long are the same as the first case on time start ones, including instrument issues and room setup and cleaning. 45 minutes is a reasonable goal, and we'll try to aim for that. Anything better will be much appreciated. So I'll aim for anything better than that as well. And that's basically the end of my talk. I will be sending these recommendations to our team and the APPs, and I'll coordinate with Leslie to see how we can make this process a much smoother flow.
I just want to comment. So thank you, Susie. That's a lot of information that she presented. We're going to work on the actual implementation and the execution of these over the next few weeks. We've been talking to various people, not only in POMA leadership, Amandarie, and so forth, about making this as seamless and easy for all of us as a department as possible. We have a lot of buy-in. A lot of people are very motivated to help us. So I think this is a great opportunity. As we get more concrete recommendations and timing, we'll have a follow-up meeting for all of you to discuss that. But I wanted us and I wanted Susie to really have this opportunity to discuss it. So thank you for that.
Susie, that was outstanding. Thank you.
Thanks.
It was outstanding. And this is a serious issue. It has caused death in our patients. It is, you know, it's not isolated to one type of surgery, one room, or one surgeon, we have shown. And it seems to have become entrenched up until the COVID. So really excited to have you on board and to solve this problem. If you can then also solve turnover, you're going to be a hero. We'll see. That, my guess is that's going to be a harder one to solve, but I would love to work on that too. All right, everyone. Thank you. It was a good grand rounds today. See you next week.